Thank you so much for the kind words of introduction, sir. At the outset, let me congratulate Dr. Kumarvel and the team for a spectacular conference. And thank you so much for having me here today and giving me a topic which is one of the most fashionable topics, I would say, in the current times. And today I'll be talking about GLP-based therapies, especially focused on semaglutide, and what we all should know. It's not just physicians, what we all should know when we talk about it. And I'll be covering my topic in the following headings. This is my disclaimer. I have no conflict of interest, and if there is any overlap with any trade name or anything, it's just for educational purpose only. And today I'll be talking about, in these following headings, what is known already, and what is the baseline knowledge that we all should know, and what is the good, bad, and the ugly of the molecule that we're talking about, and what should we know before starting, during the therapy, and long-term management. In short, we can say that what should be known for the sake of knowledge and what should be known to save. Save not just the patient, save our neck also. So where are we legally correct and where are we legally liable? So starting our history with this GLP-1, incretin effect was known way back 60 years ago from where we are right now. It took almost 30 years to understand that exindin 4 exists in Gila monster. And then from there, another 20 years to starting liraglutide. And then again, we are here today in 2026 talking about semaglutide. So semaglutide is the topic of interest today, and we need to know about what is the baseline about this molecule, what are the game rules, and what is the drug, impact of the drug at the baseline knowledge, and what are the effects of it. And then the game rules, understand the molecule and understand what our government is trying to tell us about it. So it's a Schedule H drug. That means it should not be sold over the counter. And CDSCO has currently approved 25 brands from 11 companies for type 2 diabetes and obesity usage for this molecule. And DCGI says that the approval will be there only when a phase 3 trial is done in Indian patients. So Indians, if it is approved by DCGI, you are safe to prescribe it because we know this particular molecule in the Indian context. And then when should it be given? When BMI is more than 30 or when the BMI is more than 27 with at least one weight-related comorbidity. That is when we can prescribe these medications. So let us understand the molecule now. The drug, when it was started by the originator molecule is processed by RDNA, lengthy process, stepwise process, purification happens, and we have the originator molecule, the Ozempic, Wegovy, and all that. So after we've understood the originator, original biologic, just like insulin's biosimilars we talk about, we have biosimilar right now. It is also made from RDNA data technology, but few steps may be different. So efficacy may be similar to that. And then we have another class of semaglutide, which is synthetic. That means if you're beading a pearl chain, how would you bead it? On a string, you'll be putting up a lot of pearls. So like that, on a peptide backbone, you're putting up each amino acid and you're creating a synthetic molecule. And most of the data of efficacy, safety, everything we have for the RDNA technology molecule, and synthetic copies, they're supposed to behave like the RDNA copy only. This is what we need to know about what the molecules are there outside first point. The next thing that we're talking about, the types were synthetic and RDNA. And then while the route of administration we talk about, we have the oral as well as the injectable forms. We all know this. Ribelsis has been there for quite some time, and then now another molecule has also come up. And another thing, very, very important, pertinent thing we need to know about the basics of it is, for the injectable mainly, we have to maintain the cold chain. It's not just about where it is manufactured, how it is manufactured, no. How is the patient storing? Where is the patient carrying this? Especially in our summers, it is told that entire country is near the sun much more than any other country, and Tamil Nadu is in a different place completely, near the totally orbiting nearer to sun. So that is the summer intensity that we perceive in our southern states. So we need to be a little more careful about the cold chain that is out there. So this is about the baseline knowledge about what is the background about the drug and everything that we all should keep in mind before we think about this molecule. Now let us see the good, the bad, and the ugly about this molecule with regards to the disease, the drug, and the effect. So the good initially is, we know that Differenza has put out 8 pathophysiologic mechanisms in which type 2 diabetes can be caused. So this molecule addresses significantly 6 out of the 8 mechanisms, except that excess glucose reabsorption by kidney is not addressed by it. And indirectly, it impacts the muscle. So 6.5 points out of 8 handling. So it is not just for obesity, but for type 2 diabetes, it works very, very efficiently and well so. So that is about the disease and the molecule when we are using, we need to understand. Okay, we started using semaglutide. What could be the benefit on the weight? We are saying anti-obesity medication, there should be some significant benefit about it. So what is the benefit about it? We see about 18% weight loss. Glycemic control, as Dr. Srinivasan was mentioning, there is a very good glycemic control and 2.8%. Not just sugar control or not just the impact on weight, it directly gives a lot of cardiovascular benefit with up to 26% MACE reduction. We need to understand that these molecules are important for cardiovascular outcomes and in a positive way. And then what about kidney? Even though it doesn't impact the renal reabsorption of the glucose in diabetes, it has very good protection on the kidney. Because of the good protection on the kidney, there is 24% reduction in the major kidney related side effects which are there. And then liver benefits, Essence trial has clearly shown it that in benefits on the liver are quite a lot, to up to almost nearing up to 40% benefits on the liver. And then all-cause mortality also benefited. So these are the good things about the diabetes and metabolism and longevity, all these things, cardiovascular, kidney and liver benefits. So what are the other benefits? We have now flexibility. It can be given orally or it can be given injectable formulation. And February 2026, by SOUL trial showed that MACE improvement with the oral semaglutide was also 27% MACE improvement. It can be used. Coming to injectable, extensively studied, we have a lot of safety data. It provides significant HbA1c reduction and the mean reduction in total fat. When we're talking about weight reduction, we are not just losing fat. We want to hear fat, but it is not just fat. We are losing muscle, we are losing water, we are losing stored glycogen, we are losing bone also. Amidst all these things, the most important and metabolically stabilizing tissue in our body is muscle. So we are losing muscle also, and that is something which is concerning. As Dr. Shanmugh Sundaran was also mentioning, that we need to use these despite frailty which is present. We need to use, why? Because the percentage of fat loss is much more than the percentage of the muscle loss. And if we take care, we can preserve that muscle and let most of it fat go away. So relative increase in muscle percentage is present when we say weight loss with these medications. And it is, I think semaglutide is approved in, I'm so sorry for that. Yeah, and semaglutide is approved in almost 75 countries, and that's something really good. We need to understand that world over it is a molecule which is prescribed very much. So as Dr. Srinivasan was showing, it's a very high efficacy drug, not just for glycemic control, but also for weight lowering effect. And Sustain 6 Essence, definitely we have seen cardiovascular trials, outcomes are very good. MASLD, it is good, and flow, kidney, it is good. So we've come to the good. So could there be bad about this molecule that we are so happy prescribing, so many benefits? Can there be something wrong with it with regards to the disease, drug and the effect? Let us see that. Obesity is no longer called obesity. It is ABCD according to ACE, and we should call it that. Why? It is adiposity-based chronic disease. So it is not just fat accumulating, it is the bad kind of response which the fat is generating because it is at bad locations, different locations where it should be, and it is generating different compounds, and that is causing the problem. But when we talk about GLP-1 receptors, are they present on this adipose tissue? Answer is no. We are treating a disease which is impacted by indirect mechanisms, central mechanisms on the weight. But directly, there is nothing. So there is something else to the story probably which we are missing. And then our factory in the body, liver, it also doesn't have GLP-1 receptors. So two main tissues which get impacted, there is benefit, but there are no GLP-1 receptors. So definitely there is something else. And then as we spoke about kidney, though there is benefit, the kidney is not affected. That is also a little bad. And then there is no direct impact on the muscle. Muscle is one tissue, when activated, produces a lot of myokines. These myokines go and talk to the liver and other organs, and then that is how the intercommunication happens. And then this muscle is also not getting impacted directly. Maybe we're losing a little muscle if we don't preserve it. So these are a few bads that we're talking about. Additionally, what are the bads about the drug in itself? The bads about the drug is that oral medication needs to be taken in a particular way. You have to take it because it can be digested in the stomach. You have to add it to a particular molecule called snack, and then we give it. For that, you need to take it with minimum amount of water, up to 120 ml, should not eat or drink for 30 to 60 minutes, should not interact with any other medication. This especially problem comes in with those individuals who also have hypothyroidism, whom we tell, take this medication first thing in the morning. Now the patient comes in, you told me 2 medicines to be taken on empty stomach, which one should I take? So this is very practically important point. What my patients do in Hyderabad is that they wake up, put an alarm at 3 o'clock, take this medication and sleep. When they wake up, they take the first thing in the morning, they take the levothyroxine, and then by the time they finish their everyday routine, it is half an hour to 45 minutes and they are good to go with both the molecules. And that has worked in the practical scenario at my end. So next is cold chain maintenance. We are in the summers, actually correct time to talk about this. Cold chain maintenance is very important. Please tell them to carry it always in a proper way, and explaining that will keep the efficacy of the drug going. Else it's all the money wasted, all the pricks wasted as well. And next, about the GI disturbance. It is well known to cause nausea and vomiting, and a little of diarrhea is also seen. But how do we combat this? By 3 E's. The patient is coming, doctor, I took the medication on Monday, and then by Friday the patient is saying, I'm having a lot of nausea, I'm not able to handle anything. What should I do? What should I do? And your inbox is full with that particular patient's mails. What do? You educate them about the temporary nature of it. You educate them about taking small frequent meals. You educate them about the potential side effects and when the real red flags occur. So these are important points which we need to talk about when we talk about the molecule. Case 1, given 112 kgs, by Friday you have 10 males, nausea, please do this, please educate them, please talk to them about this. And then dehydration. Along with suppressing the appetite, it also suppresses the thirst cues. So patient 2 has come and walked in and saying, doctor, you said I will not lose any weight with 0.25 mg, and now in first 1 week itself I have lost almost 1.5 kgs. Ask the patient whether they have hydrated well or not, because hydration gets affected very badly. And in Indian summers, it's imperative to address hydration. Dehydration is the cause of initial weight loss, which you see in the first 1 to 2 weeks if the patient is taking inadequate fluids. And then sarcopenia risk, yes, we've discussed this, that is definitely present. And then Government of India has come up with certain care guidelines and then warnings about Ozempic phases. We talk about very informal way we say about certain things. Go low, go slow, else not on the record, else you'll become like Kejo, Karan Johar, because he's supposed to have like that. So informally we say that. So go low and go slow is very important, because subcutaneous fat is lost and the skin sags down because of the rapidity of weight loss. So don't be very eager about the numbers, take the numbers very carefully. Your metabolism should move alongside the dosage of the medications. That is the important point that we are talking about. So these are the goods and bads, and then is there any ugly? Is there something really bad things about the medication? Let's talk about it. So GLP-1 receptor agonists, they work by binding to GLP, and then they increase the insulin production and decrease the glucagon production. In doing so, what happens is there can be overstimulation, ductal blockade, and increased enzymatic stress, and subsequently pancreatitis. Very, 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 very rare, but it is present. Patient 3 is walking in, and then patient 3 says, doctor, I have nausea, vomiting. It's okay, go. No, ask about whether the abdominal pain is there and severe. See whether there is tachycardia, see whether there is fever. If it is present, do not just rule out as temporary thing. Pancreatitis is real, rare but real, but why not this one patient? We are dealing with a country of billions, right? Millions, billions, whatever. So the numbers are huge, obesity is huge, problem is real. So definitely that one patient can be a patient of pancreatitis. So keep it in mind. Severe upper GI pain, temperature, patient is febrile, tachycardia, all these are present, nausea, vomiting. You show him food and then he's vomiting, he or she is vomiting, and then don't even show me food. Suspect is the first step where we look at pancreatitis. Then though rare, there can be frozen stomach, sometimes temporary, sometimes permanent. Scary, right? Gastroparesis is known because it slows down gastric motility, and temporary is very well known. That's what we are educating the patient. That's why nausea is there. But tell them about it. Next, pulmonary aspiration. This is a patient of long-standing duration of diabetes and obesity, and you have started this patient on GLP-1 receptor agonist. Already there is probably autonomic neuropathy. Already there is gastroparesis which is there. Already you're giving this, and this is all. Everything is slowing down pretty much. So what is happening? There is a risk of pulmonary aspiration. And then the controversial NION which is there, the sudden unforgiving vision loss which is present. Is it real? Yes, we have seen it as real, but is there any causal connection? No causal connection. As of now, in patients using semaglutide injectable, 8 events per 100,000 patient years and 7 events in placebo shows good, but maybe focus trial when it comes up, maybe we'll know much better what we are dealing with and how much more careful we should be. But then remember, this is irreversible. So when we are remembering a few things here, in practice, how should these things translate to, we have to understand. After speaking all these things, there are certain individuals, whatever you might do, they will not lose weight. Doctor, I'm using this medication since 3 months, you have increased me from 0.25, 0.5, now I'm using 1. Other than a little of nausea, vomiting, there is nothing changed in my weight. Hardly 1 kg I have lost. What will you tell this patient? There is a published evidence right now which says there are genetically different individuals, and because of that genetic difference there is non-response. First ask about the compliance, then ask about the weight loss which is there, and then see. If there are non-responders, please stop the medication. This medication is not for them. So what do we know before, during and after? This is one of the most important things we need to understand. Before treatment, ask for thyroid cancer risk, MTC men risk. It is important. Document it in your prescription when you're writing. I have asked the personal and family history of MTC, medullary thyroid cancer, and men too. Ask about past history of pancreatitis or behaviors leading to pancreatitis. Alcoholism is very, very common. इस देश में गंगा बहती है, इस देश में alcohol भी बहता है. Please ask. And then pregnancy. This is definitely contraindicated in pregnancy. If the woman does not have cycle and the last menstrual cycle is not known, document LMP which is there, which is very important. And if you're using this in a reproductive age group woman, drug washout of 2 to 3 months is essential. So pregnancy history should be asked about. Establish baselines. Know where you are so that we proceed to where we want to. Document HbA1c, renal function, liver enzymes, and lipid profile. This is essential. And eye screening is mandatory. The patient should not say, you started me on semaglutide and I lost my vision. No. Always remember that irrespective of the modality of the treatment used, if there is a rapid correction in blood glucose level, there can be worsening of retinopathy and sometimes neuropathy also. So because that can be there and rapid correction of glucose can be present because now the patient is compliant, now the patient wants a difference in weight, going on diet, going with lifestyle, everything is good. Now probably the patient doesn't need so much of anti-diabetic medication, and then there is retinopathy worsening, remember that. And then when you look at medications and the patient is on insulin and other sulfonylureas, reduce the dose by 20 to 50% to prevent hypoglycemia. So this is before you start what you need to remember. During the treatment, start low, go slow. We've touched base on that. And then dose titration definitely is required. And then GI intolerance, the 3 E's, the education, slow escalation, and effective meal. This is very, very important to talk to the patient about. And then severe pain, always report. Any pain, report. Probably that one odd case is the case with pancreatitis. Keep that doubt higher. And then rapid weight loss, always the risk of cholelithiasis is on higher side. So keep that in mind. And then because thirst cues go down, talk about dehydration, talk about the renal risk. And then perioperative guideline, because there is gastroparesis, semaglutide should be stopped at least 1 week before any elective procedure. Why? Because the risk of aspiration is real. So we have to keep that in mind. So after starting long-term monitoring, what do we do? Non-responders. Less than 5% weight loss in 12 weeks on maintenance dose, stop the medication. They are not responding. Psychological monitoring. After burning our fingers with rimonabant, sibutramine, we need to be careful with whatever changes or acts by the central mechanism. So keep it in mind. Keep it in mind that depression can improve, and depression may be because of the body image and other issues, but then always keep asking those questions. Dr. Shanmugh Sundar also showed about what do we need to ask. And physical maintenance, resistance exercise and high protein intake are essential to maintain the muscle mass, and continuous labs, at least 3 to 6 months, you need to look at your renal function because of dehydration, AKI that can be present, and HbA1c needs to be monitored. So summarizing, baseline, there is convenience of 2 types of dosing. There are 2 types of medication which are available, semaglutide, rDNA and synthetic, and then you have oral and injectable. Then the good is about the obesity treatment, diabetes remission, CV benefit, kidney protection, MASH improvement, osteoarthritis improvement. And then GLP-1 bad are all these factors that we discussed about. Then we have cold chain maintenance issues, GI distress, dehydration, sarcopenia risk, Ozempic phase. So keep that in mind. Ugly are all these things, so keep them in mind when you're writing a prescription. So ending my talk with one case scenario where is a type 2 diabetic individual who has come up, and the patient is on sitagliptin 100 milligrams, metformin 500 milligrams, and SGLT2 10 milligrams per day, and is 112 kgs right now, and you started GLP-1 receptor agonist. What am I missing here? Can anyone tell me? I have not stopped DPP-4 inhibitor. So very important to remember that the drugs which we use very commonly, DPP-4 inhibitors, should be stopped for two reasons. Because GLP-1, RA and DPP-4 when combined, they act, there's no potentiation of action or synergistic action. They just act through the same mechanism. It's redundant when we add both of them. The risk of pancreatitis, risk of side effects increases when you're combining them. So maybe not with the smallest initial doses, but later on the risk is higher. So stop DPP-4 inhibitors before you start GLP-1 receptor agonists. Thank you so much for indulging in me.